I'm David Simons. I'm a medical doctor and a PhD candidate based at the Royal Veterinary College. And today I will be presenting our case control study designed to investigate the association of former and current smoking with hospitalisation for COVID-19.
This work has been conducted alongside Olga Persky, who you will hear from later today, Leon Shahab and Jamie Brown from University College London, and Robin Bailey from the Hospital of Tropical Diseases based at University College London Hospital. As will be discussed in depth later, we know that former and current smoking is associated with an increased risk of respiratory viral infections,
such as influenza and respiratory syncytial virus, with some evidence of worse outcomes, such as increased rates of bacterial superadded infections among these populations. However, as the Living Review showed, the association of smoking and COVID-19 is less clear, given the short time that it has been around. Importantly, the identification of risk factors for an infectious disease depend on when they are investigated in the disease's time course. Further, comparison to a population that is not at risk can also be problematic, and these are two of the issues faced when conducting research in an emerging pandemic. From our earlier work, we also identified that a majority of studies were conducted using retrospective data obtained solely from electronic health records. Electronic health records are known to have some flaws, particularly in relation to smoking research. In acute and emergency situations, patients may not declare their smoking status. They may not be specifically asked, or they may not be recorded in the correct part of the summary EHR. The summary EHR here refers to the patient's demographic, medical history, and smoking status, which can typically be pulled out, and the data can be used for further analyses. We designed this study to address some of these questions. We aimed to estimate the risk of hospitalisation among former and current smokers for COVID-19, compared with other respiratory viruses from the period prior to the emergence of SARS-CoV-2. We aimed to compare current smoking prevalence in cases with local population prevalence in London. We also aimed to identify potential discrepancies between smoking status as recorded in the summary EHR when compared to the contemporaneous medical notes that made up the full health record. To address these aims, we designed a retrospective case control study at a single hospital site in London. The protocol was pre-registered on the Open Science Framework, along with a sample size calculation to ensure adequate statistical power for the planned analyses, and this was based on prior data. We enrolled cases from a consecutively admitted population of adult patients from the 1st of March 2020. At this point, community transmission of SARS-CoV-2 within the UK was accepted and identified. All patients were required to have lab-confirmed COVID-19. A cutoff for confirmation of COVID-19 was set at 5 days, and this ensured that we were able to exclude those that had acquired infection within the hospital. We enrolled controls from consecutively admitted patients from the 1st of January 2019 up until the 31st of December 2019. This time period was prior to the first recognised imported case of SARS-CoV-2 in the United Kingdom. Patients were required to have laboratory confirmed non-SARS-CoV-2 respiratory viral infections. Individuals already admitted when testing positive for respiratory viruses were excluded from the sample, alongside those without any record of smoking throughout their electronic health record, or available documentation from primary or social care teams. We performed logistic regression adjusted for age, sex, and comorbidities to test for an association between smoking status and the cause of admission to hospital. We performed one proportion Z tests to compare current smoking prevalence in cases with 2019 local smoking prevalence from data available from the Office for National Statistics. We performed chi-square tests to investigate an association between the summary electronic health record smoking status and that documented in the medical notes. 550 controls were identified as having an admission related to respiratory viruses based on their International Classification of Diseases code within the registry. This was the ICD-10. 180 of these were under 18 at the time of admission and so were excluded. A further 38 were found to be in-hospital infections. 39 patients were not admitted to the hospital. 29 had non-respiratory infections. 36 didn't have any evidence of infection within the record, and 3 had no data on the whole of the admission. 14 patients were also excluded for having no documented smoking status within the electronic health record. Around 600 cases have been hospitalized up until the end of August. We have extracted data on 399 so far, and that has formed the interim analysis. 8 patients were excluded because they were under the age of 18 at diagnosis. 33 were likely infected while in hospital. 6 didn't have virologically confirmed COVID-19, and 3 patients were not admitted to the hospital. 36 patients didn't have any documented smoking status. Most of the control population were admitted with a primary diagnosis of influenza A and parainfluenza. Around 12% were admitted with multiple viruses being detected on their initial investigations, some of which included influenza. And very few patients were admitted with endemic circulating coronaviruses. The control population was predominantly female, but like the data that we've seen from multiple other studies, patients admitted with COVID-19 were more likely to be male. This graph shows a similar median age of hospitalized patients and controls. The median age of cases is 66, and of controls is 63. However, there were a large proportion of relatively young controls, which wasn't seen in the case population. This map shows where in London controls, the map on the left, and cases, the map on the right, were admitted from. The black dot in the centre of the map is sited in Euston, the location of our hospital. These maps show the overlap in the regions from which controls and cases were admitted, highlighting the hospital's catchment area within London. Cases were admitted at greater rates from inner city regions in the north and northeast part of central London, and these are the red and orange regions on the map. These areas in particular suffered high rates of infection early on in the pandemic. Patients from further afield in the northwest and east of the cases map were admitted after local hospitals were overwhelmed with patients in March and early April. Further differences between the populations include the length of stay following admission. Median length of stay for respiratory viruses is 4 days. However, this was more than doubled for cases at 9 days. Mortality was also significantly increased, with just under a third of cases not surviving to hospital discharge. And this compares to an in-hospital mortality of around 4% in the control population. It must also be noted that patients that died were more likely to have been excluded from being enrolled in the study as a case, as they were more likely to have no smoking information due to the extreme state in which they attended the hospital, or if transferred from another hospital, they often didn't have information on smoking status or any previous encounters with our study site. Metabolic conditions such as diabetes and obesity were present in higher rates among cases, alongside cardiac conditions such as hypertension, previous heart attacks, and arrhythmias, and this is similar to what has been reported elsewhere in the literature. Current or former cancer was lower in cases than controls. However, this may reflect the hospital population. This hospital is a referral centre for a range of different cancer diagnoses. Cancer patients are at greater risk than the general population for being infected with respiratory viruses, and this may reflect the high proportions in both populations of greater than or around 20%. The proportion of current and former smokers differed between the two populations. The local smoking prevalence within London of 12.9% is represented here with the black line. Controls had a higher smoking prevalence than the local current smoking prevalence, and there was a smaller proportion of current smokers among cases than controls. A larger proportion of former smokers among cases than controls was also observed. Following adjustment for age, sex, and presence of the above comorbidities, current smokers had a reduced odds of being cases and controls. There was no difference in former smokers. The proportion of current smokers in the case population was also significantly lower than would be expected from the overall London prevalence of 8.6% against 12.9%.
We then went on to look at this stratified by age for 3 age groups, 18 to 44, 45 to 64, and 65 plus. These groupings were chosen to match to the London data, but also to explore the time period in which smoking-related diseases may become apparent. We performed one-tailed non-inferiority tests to identify the presence of a significantly reduced prevalence of current smoking when compared to the local prevalence. For the 45 to 64-year-olds group, there was a significantly lower proportion of current smokers. The proportion of current smokers in the other age groups were not found to be statistically significantly lower than expected. However, as can be seen, there are very few participants that fell in the 18 to 44 age band, and so the point estimates are likely unstable and sensitive to the sample size.
Smoking status was poorly recorded on the summary electronic health record, with significant discordance from the status recorded in the contemporaneous medical notes and clinical letters. This was higher in the controls than in the cases, and this can be seen in the following graph. 75% of the control population had no recording of their smoking status in the summary electronic health record. This was massively improved in the case population. And a reason that it is not poorly recorded among the cases is that there is an ongoing research study in COVID-19 survivors where smoking status is explicitly ascertained by telephone interview and entered into the summary EHR. We expect that in settings outside of a research environment, the control population more closely matches the real-world situation. This is something we have seen recently with high amounts of missing data in studies included in our living review. So to summarize, this study found that current smoking prevalence in cases was significantly lower than in the control population. There was a lower level of current smoking prevalence in those admitted with COVID-19 compared with the general population among those aged 45 to 64. Cases were more likely to have longer hospital admissions and higher mortality than controls. Cases were also more likely to have comorbid cardiac and metabolic diseases compared with controls. Smoking status is generally poorly recorded in summary electronic health records. This study and others highlight that while COVID-19 shares a similar route of infection, it has a very different pathology to other respiratory viruses. A significant proportion of COVID-19 associated mortality is attributed to a hypercoagulable state, causing end-organ ischemia and stroke, with those with predisposing factors such as type 2 diabetes and hypertension more likely to be admitted to hospital and have worse outcomes. The role of current and former smoking in this are not clearly understood. The cause of the lower prevalence of current smokers in the middle age group is unclear and cannot be elucidated with this study design. It is unclear if this population are firstly at reduced risk of infection, secondly have a reduced risk of severe disease once infected, or thirdly, they are not being exposed to the virus at the same rate as other sectors of the population for some as yet unmeasured reason. This study design is further limited by several factors. The control population selected here were significantly different in a number of baseline factors. In particular, cancer prevalence was significantly different, and this was not expected a priori. The reliance on health records resulted in the exclusion of at least 56 potential participants with data unlikely to be missing at random, with those with worse outcomes more likely to be excluded because of this. This study design is further limited by several factors. The control population selected here was significantly different in a number of baseline factors. An example of this is that cancer prevalence was significantly different, and this was not expected a priori. The reliance on health records resulted in the exclusion of at least 56 potential participants, with data unlikely to be missing at random. Those with the worst outcomes were more likely to be excluded because of this. Echoing the living review, we recommend that prospective representative studies that explore the entire disease course are implemented to investigate the association between SARS-CoV-2 contact, infection, disease, severity, and then mortality. The codes for this analysis is not currently available, but will be released alongside a suitably anonymized dataset in the future. I would like to thank my co-authors, the data team at UCLH for providing the pool of cases and controls, and all of the patients and staff at University College London Hospital that have made it possible to explore these associations. I look forward to answering any questions you may have in the discussion session. Thank you.